Awesome. All right, everybody. We're non-productive cough and dysphonia. Our expert clinician is Dr. Spec. Before we get to introductions, we do have some disclosures. Dr. Spec receives grants from Astellas and consults for Revimmune, Basilia Pharmaceutica, and F2G. All other planners, presenters, faculty, reviewers, others in control of content report no relevant disclosures. All right, to our amazing expert consultant, Dr. Spec. He's currently an associate professor of medicine here in the Washington University Infectious Disease Department. He went to medical school at the University of Illinois College of Medicine in Chicago, Illinois. He did residency at Rush University in Chicago, and he did his fellowship here with us at WashU in the Infectious Disease Department. He also got a Master's of Science in Clinical Investigation here at WashU. He is internationally renowned for his work in fungal infections. He studies epidemiology and factors that affect outcomes in patients infected with fungus, both in the US and globally. He serves as the Associate Director of the WashU Infectious Disease Clinical Research Unit and is actively involved in the mycosis study group, through which he participates and runs multi-center studies centered around invasive fungal infections, and is the creator and leader of the Washington University Mycosis Group, a consortium of researchers interested in fungal infections. So, Dr. Spec, I take it that you like fungus. Is that all right?
Mild obsession.
Yeah. Also, interestingly, Dr. Spec was also on the internal medicine podcast, The Curbsiders, recently. It was a really phenomenal listen. It was about 1 or 2 months ago. I used that episode to prepare for this case. That's your only hint, Dr. Spec. All right. So, non-productive cough and dysphonia. Dr. Spec, what are your initial thoughts, and if you have any differential diagnosis?
Yeah, so I usually like to kind of write down what I think could be the cause based on this. My initial thought, if you talk about this worldwide, this is going to be, number one cause of this is going to be viral, right? All right, I think that's my microphone being naughty. I apologize. The other thing that where I kind of focus on this is this laryngitis? So what are the causes of laryngitis? In addition to viral, a really common cause of laryngitis, surprisingly, is actually Candida, especially in people who have received antibiotics or steroids for their viral infection will then get a candidal overgrowth of the vocal cords. There are other fungi that can cause kind of an invasive granulomatous laryngitis, such as crypto, histo, blasto, cocci, TB is also worldwide an important part of it, and it's actually an important differential to know because laryngeal TB is by far the most infectious of all TBs, so it has really big, important infection prevention implications. Theoretically, NTB, non-tuberculous mycobacteria, Bartonella, and Coxiella can all do it, but they're much less likely. The other thing you worry about is retropharyngeal abscess, causing kind of direct compression. Post-COVID syndrome can also cause it, although I'm guessing you probably aren't presenting a post-COVID laryngitis or a hoarseness of voices like a long COVID syndrome. Botulism and tetanus also can cause dysphonia as a result of an infection, which then causes neurological damage. Although you're telling me also that the patient's chewing tobacco, so the first thing that should also be on the differential on the non-infectious side should be cancer. And then whenever I list infiltrative granulomatous diseases, I also include lymphoma, because anything that any of them can do, so can lymphoma. There are also neurological and stress causes of dysphonia, allergies, GERD, eosinophilic esophagitis, COPD, and trauma. And then on the rheumatoid side, there's sarcoid, RA, Sjogren's, amyloidosis, granulomatosis with polyangiitis that are all associated with that. And then there are medication causes of dysphonia, and that's kind of what I'm focusing on as the main thing, thinking that the fact that there's also a cough kind of connects me more to an infectious cause, and the fact that I am here also connects me more to an infectious cause. But nonetheless, I think there's multiple reasons for that, but I still kind of want to give an exhaustive history. And so inhaled intranasal steroids can cause it, both directly by steroids getting onto the vocal cords, as well as causing a candidal overgrowth. Anticholinergics, antihistamines, decongestants, and antihypertensives are kind of the ones that have been implicated in dysphonia. And so when I see this first, the thing that kind of populates in my head is, what do I want to do for the patient? And the first things I want to do is, the first thing I always want to do is I want to take a history. I want to take a detailed history, including a travel history, because we're ID and we need to know everything, including the name of their dog. I want to do a really good physical, because one of my favorite mentors in medicine, Stu Levin, once told me, if you're a proper doctor, 85% of your diagnoses should come from a history, 10% should come from your physical, and the other 5% you screwed up on. And so the other thing I'd like is routine labs. And then assuming that I don't hear anything crazy from those things, I'd like a CT neck to see if there's retropharyngeal abscess or any kind of a compression there. And then if those are unrevealing, the next step would be an ENT consult for a scope of the larynx. So I'll stop there, and then I'd love to hear the rest.
All right, well, very good. That's a very, very broad differential, very, very impressive. I'm hoping that some of our history can kind of narrow down some of the differential. All right, so patient has had a non-productive cough for the past couple months and has noted her voice becoming hoarser over the past year. She was recently diagnosed with a strongyloides infection in the setting of eosinophilia, is now status post ivermectin for 2 doses about a month prior to current presentation. She saw an ENT specialist just given these voice changes, and she was prescribed omeprazole, which seems to have helped her symptoms. Over the past year, she's experienced weight loss about 11 pounds, which she attributes to loss of appetite, and her PCP begged her to present to the emergency department, which is where she's at now. All right. Going through the medical history again, she has a hypertension, type 2 diabetes, this chewing tobacco use, and then this recent diagnosis of strongyloides, now status post ivermectin for 2 doses about a month prior to presentation. She also has a history of cataract surgery. Family history, her son had a stomach tumor, questionable, not really well fleshed out in the EMR, but this son was living with her and is now unfortunately deceased. No known drug allergies. Medications that she currently takes is amlodipine, atorvastatin, gabapentin. And as you mentioned, Dr. Spec, social history seems to be really, really important for the infectious disease evaluation. So let's dive into that. So she immigrated to the United States from Laos 20 plus years ago. And for those of you who need a refresher on geography, Laos is neighbors Vietnam and Thailand and is south of China, so in Southeast Asia. She used to be a farmer in Laos. Currently in the United States, she's mostly homebound and now lives with her daughters. Denies any travel since immigrating, denies any sick contacts, no pets, has been using chewing tobacco for 20 plus years, but denies ever smoking, denies alcohol or illicit drug use. Does this answer any of your questions, Dr. Spec? Not sure.
I'm not sure if it answers my question, but it does make certain things more likely, and it brings another thing to the differential. So with her location where she's at, the one thing that comes to mind is Telleromyces as a possible cause, which some of you may have learned is penicillium. It's the name that we've been using for a few years now for the old Penicillium marneffii. That can also cause this kind of a disease. TB becomes more likely, and the eosinophilia kind of raises the probability of the endemic mycoses some, but really specifically coccidioidomycosis if she's actually had any traveling, although I'm not seeing any for that, but cocci is notorious for causing eosinophilia. She does have risk factors for strongyloides, so that seems like a reasonable diagnosis, although we don't usually test for it anymore. It's usually a clinical diagnosis. So I wonder how her eosinophilia responded to the ivermectin treatment.
Very good. Just briefly going through review of systems. So she has had weight loss about the 11 pounds over the past year, which she attributes to that loss of appetite. No fevers, chills, or night sweats. Has had that voice hoarseness, but no changes in hearing or vision. Cough, but no hemoptysis, doesn't bring up any sputum. Denies shortness of breath or wheezing. No chest pain. Has had on and off constipation for the past year, but no other GI symptoms. Denies any rashes. No sensory or weakness. So yeah. All right. So just to kind of go off of this history, what exactly are you looking for on physical exam for this patient?
I also kind of had a thought of possibly like Loeffler syndrome or strongyloides hyperinfectivity syndrome, but again, she's not that sick. Usually those folks are very, very sick. In terms of physical exam, and I kind of want to have a really good skin exam. I want to see in a very good lung exam. So does she have any specific losses in her lungs? Does she have any nodules? Because they would be very common with some endemic mycoses, and with tuberculosis is also not an uncommon thing. I'd also want to know if does she have any personal history of tuberculosis? Because the other thing that comes to as a possibility is CPA, or chronic pulmonary aspergillosis, which worldwide the number one cause is post-tuberculous. And so that could be a possibility. So those are the kind of the initial things I'm looking for. But then also, whenever you have an unsure diagnosis, it's good to cast a wide net.
Fair enough. Fair enough. Well, let's see what they saw on physical exam for her. So vitals were normal. She's satting 100% on room air. She's afebrile, normal blood pressure, heart rate, respiratory rate. She's well appearing and no acute distress. Only notable finding is that she has poor dentition with tobacco stains, but no palpable lymphadenopathy. Thyroid is non-palpable. Oropharynx is unremarkable. She's regular rate rhythm on cardiovascular exam, and the pulmonary exam, she is clear to auscultation bilaterally, no wheezing, rhonchi, or crackles. She's soft, non-tender on abdominal exam, no hepatosplenomegaly is palpated, and no obvious rashes on a very thorough skin exam. All right, so not particularly helpful, right, Dr. Spec?
Not horribly helpful, but there is a thing that it brings up as another possibility would be actinomycosis. So that is very strongly associated with poor dentition and can cause both laryngeal disease as well as pulmonary disease. And usually with that, you'd be seeing an empyema necessitans, which would kind of be it would be a very interesting differential in her to have an empyema necessitans.
Well, very good. All right, let's move on to initial lab work, and I'll give you both chemistries and CBC on her. So electrolytes are normal, kidney function is also normal, but looking at those liver function tests, she did have alk phos that was elevated at 229 a month prior when she was diagnosed with strongyloides. Since treatment and now on current presentation, her alk phos is 149. Her AST was 390 1 month ago, again at this diagnosis of the strongyloides infection, now 110 on presentation. We don't have an ALT from 1 month ago, but it's currently 117, and we don't have any prior labs to look at for liver function tests. So just looking at these liver function tests, what sorts of infectious etiology are going through your mind, and what should we be looking for?
So it doesn't dramatically change things, other than to say that it's nice to see the response in the eosinophilia, because that would suggest that maybe it was indeed strongyloides or another ivermectin responsive parasite that she had. The elevations in alkaline phosphatase and her liver enzymes are kind of suggested that she might have like a reticuloendothelial infection. Which in her, the differential for reticuloendothelial infection would be tuberculosis, Telleromyces, TB as the kind of the big markers of it. The fact that the AST is pretty close to ALT is kind of suggested that it's not just the liver, because if you had just liver, it would be more ALT predominant. But the interesting thing is that the leukocytosis, which is neutrophilic in right now, which kind of pushes more towards something like actinomyces or another cause of kind of a neurophilically responsive or something that is managed by neutrophils in our body, which amongst the diseases that I mentioned earlier at the beginning, blasto would be associated with that. But I'm not seeing really much else that would suggest that blastomyces is on there. So I think that's kind of my initial kind of moves ups and downs in terms of probabilities.
Gotcha. And you were talking about the CBC already, the leukocytosis to white count of 15.8, a hemoglobin of 8.7, but this marked markedly decreased MCV of 58.2, so severe microcytosis. And then, as you mentioned, a neutrophil predominance of 73% of leukocytosis. And then this resolution of the eosinophils from 1 month ago to now after treatment with strongyloides. Does resolution of the eosinophil count mean that the strongyloides is, or whatever ivermectin responsive organism is resolved, or is there still a chance that there could be refractory strongyloides in this case?
It should be resolved. We see so little strongyloides that I always want to be cautious in saying, yeah, definitely it's gone, because honestly, I don't think very many of us here have the expertise to really say that, except for folks who've trained in endemic areas. I would say that I wouldn't fully eliminate it from my differential diagnosis, but I would think that in an immunocompetent patient with 2 doses of ivermectin, it should respond.
Gotcha. And then turning towards that microcytic anemia, are there any infectious causes that would lead to MCV in the 50s?
I'm trying to think. Off the top of my head, I'm drawing a blank. The way you're asking that question, I think that there is. And I think I've probably thought of it at some point in my lifetime, but not right now. I wonder if she has a profound iron deficiency anemia from having parasites. I think there are malarias that prefer different stages of erythrocytes. So I wonder if she has something along those lines, although I would have trouble connecting malaria with dysphonia. So I'm not sure I'm there yet.
Gotcha. Yeah, no, that's very fair. Would we expect like a parvovirus at all in a patient like this, or is that something to consider? Or
I don't see her having an immunodeficiency. So all of us get parvovirus without a problem, and we end up clearing it, and we don't end up with a cytopenia, unless you tell me that she has a thalassemia, that would mean that she's not clearing her. Her red blood cells have a much shorter half-life, and so as a result, they're much more vulnerable to parvovirus. But the duration of the symptoms, I think you said it was like 11 months, is just too long for parvovirus without her having a significant immunodeficiency, which we have not found.
That's fair enough. All right. So there's a lot to unpack with this case, and a very broad differential still. Where do you want to start diagnostics-wise?
I think I'd like to get imaging of her neck and chest, and so we can better define the anatomy, because we didn't find anything on physical exam. And so it would be good to see what's going on there anatomically.
Any labs that you'd want on her?
So at this point, I would start while we're doing this. I would actually take it back. I would want the imaging first, and then I would start doing the labs, because a lot of the labs that I do want are going to take days, and they would not necessarily be indicated right away. But I think the labs that are really kind of relevant here would be a T-spot, which clearly not a test to be used for diagnosing tuberculosis, but it is helpful. Although in an endemic area, I'm just going to probably presume that she is infectious. She is infected or had been infected at some point in her life. The other things to look for would be testing histoantibodies and antigen, cryptococcal antigen, blastomyces antibody, cocci antibodies. I would also want, what was I going to say? I think that's kind of where I would start, as the initial kind of opening salvo of the serologies.
Gotcha. Well, I won't be able to give you everything just now, but we'll start with a very basic infectious eval. So we got a respiratory viral panel that was negative, acute hepatitis panel that was also negative, a HIV antigen that was negative, and 2 blood cultures that resulted final as negative as well. Does this change anything so far?
No, but I would say that what it does change is that I should have said HIV, because HIV is never the wrong answer. So
Yeah.
if you get it on every single patient that ever enters the hospital, you're doing the right thing.
Fair enough. Fair enough. All right. And then let's just touch briefly about this anemia workup before we get into the imaging like you've been asking for. So I heard you mention looking for iron studies. Is there anything else that you would test for in this patient?
Yeah, I think it'd be reasonable to know that she have a thalassemia. So kind of electrophoresis of her hemoglobin.
Yeah, absolutely. And that's exactly what they did. So they got a elevated a ferritin of 738, a TIBC of 212 that was low. TSAT's normal, iron is normal. What does this look like to you, Dr. Speck?
So this looks like an inflammation.
Yeah. So anemia of chronic disease, her B12 and folate are normal. And then we got that hemoglobin electrophoresis that you asked for. And just given this markedly low MCV, and it is consistent with a homozygous hemoglobin E disease. And I wouldn't expect you to know much about homozygous hemoglobin E disease, but it's seen mostly in Southeast Asian populations, including in Laos, with a prevalence as high as 30 to 40% in certain populations. It's very commonly that patients will have an asymptomatic microcytic anemia. And interestingly, hemoglobin E is the second most common hemoglobin variant in the world after hemoglobin S. So just given these findings, the anemia of chronic disease, now seeing that she's homozygous hemoglobin E disease, are we concerned that there's infection leading directly to this anemia, or just more of a chronic kind of smoldering type?
Yeah, I'm unsure. So the last time I think I thought about homozygous hemoglobin E disease was probably the day of my step 1 exam.
That's fair.
And I can honestly say that I don't think I've ever seen it in my life. And I would say that I don't know what the normal range for people who are homozygous with hemoglobin E disease. That would be one of those things that I would let my fingers do the walking and go to PubMed and see, is 8.5 a reasonable amount for somebody who has hemoglobin E disease?
Gotcha. And I will say that her hemoglobin is typically in the 8s or 9s. So this is baseline for her.
Okay.
So, yeah.
That helps.
All right. So you've been asking for imaging. I'm going to give you some imaging. Would you want a chest X-ray, or do you want to just go straight to CT? What would you?
I would probably go straight to chest CT because you didn't find anything on physical exam. Even if the chest X-ray is negative, I'm going to get the chest CT as well, because we're going to be looking for nodules and some subtle lymphadenopathy as part of what we're looking for. So I think it would be the chest X-ray is kind of a step that isn't needed.
Well, the Barnes team thought exactly like you, Dr. Speck. We just forwent the chest X-ray completely, and we actually decided just to pan scan the patient in Barnes fashion. So we got a CT chest and CT.
Head to toe PET CT. Yeah.
So we have a CT chest and CT abdomen pelvis to go through, and we have a really special guest with us, Dr. Gutierrez. He received his medical degree from Valladolid University in Spain, completed his radiology residency in Puerto Rico Medical Center. He then completed his cardiac radiology fellowship here with us at WashU Mallinckrodt Institute of Radiology. He's a professor of radiology in the cardiothoracic imaging section and has been on faculty since 1979, which is just remarkable. That's way before I was even born. So he's internationally regarded as an expert in cardiothoracic imaging and received the International Cooperation Gold Medal from the Argentinian Federation of Radiology. It is really a true honor and pleasure to have you with us, Dr. Gutierrez.
Why, thank you, Dr. Anderson, and thank you for the invitation. I've done this many times, this conference, and I find that my role is usually very difficult, and I'll tell you why. Number one, I know the diagnosis. The person taking the case, doesn't know the diagnosis and is probably nervous. So my tendency is usually to help him or her out. And there's a limit, you don't want to give away the case, but yet you want to be as fair as possible. So I'm going to try and do that. interestingly enough, I couldn't find a chest radiograph, but I have a topogram that we're seeing here. And I think it's interesting, and I'll come back to the topogram at the end of my presentation. As you can see, and you were concerned about pulmonary nodules, and as you can see on this radiograph, on this topogram, there are cluster of pulmonary nodules, and the characteristic of these nodules is that the predilection is for the upper lobes, right greater than left. And concurrent with that is this CT scan. And as you can see, there are a bunch of pulmonary nodules, which are mostly, as I told you before, in the right upper lobe. You can see that there's a cluster there. And on the original report, they say that some of these nodules are cavitated, and that's probably not true. If you look closely, you can see that this process is bronchogenic. For example, here's the right upper lobe bronchus posterior segment, and there's that conglomerate here. There's a little bit of an air bronchogram with thickening of the, thickening of the wall of the bronchi. And again, the predilection is for the upper lobes. As we get down lower into the mid portion of the lungs, you can see that there are a few scattered, but there's not that many. The other finding is, and I think you mentioned it, is there lymphadenopathy? And the answer is yes. There's quite a few lymph nodes, pretracheal lymph nodes. Here's a subcarinal. There's some in the left hilar region. And the characteristics of these nodules is that they are necrotic. So there is an active necrotic process that is going on, destructive process, not only in the bronchi, but also in the lymph nodes. There was another, this was, I think, a week later, and the abdomen was completely normal. And again, you can see that all the scattered nodules were there. So what we have is some kind of a bronchocentric process that is infiltrating or infecting the wall of the bronchi. There is involvement of with some necrosis of the lymph nodes. Now, could this be neoplastic? Yeah, I mean, lymphoma can have nodules, but the lymph nodes in lymphoma are not necrotic like in this case. And also there's not a predilection for the upper lobes. So that leaves us with, some kind of infectious, whether fungal, bacterial, mycobacterial infections, or some kind of inflammatory process. Now, fungal would be probably less likely because they don't need to have, or they don't usually have a predilection for the upper lobes, as in this case. So I think I'm gonna leave it as that. Do you have any question? No, okay.
Here.
All right, Dr. Spec. So we have a little bit more information now. Where do you want to go with the eval?
So this reminds me of a story. When I was a resident, I would go to the ID grand rounds because I wanted to learn from these brilliant people who had been doing this stuff for decades. And I had spent so much time there that they started to, at some point, started to call on me to discuss the cases as a resident. And I was mortified. I mean, absolutely mortified. And I talked to, again, Stu Levin, who I mentioned earlier, who was the chair of medicine at the time. And I was like, I don't know how to do this. Like, this is so hard. This is so different from, like, I feel very put on spot. And he said, infectious disease discussions are the easiest thing in the world. What you do whenever you're confused, whenever you don't know what the answer is, whenever you're scared, just relax, take a deep breath, close your eyes for 5 seconds, and then say tuberculosis.
All right.
So I'm going to say tuberculosis. So I think, that's your leading to diagnosis right now. I think you really want to make sure that really at the point when you hear the words louse and cough, that patient should be on isolation. But now that you have this imaging, this patient very much needs to be on isolation. In addition to what I was already suggesting, I would also add induced sputums if possible, because he says she was non-productive cough, so she probably needs help with induction in order to get more sputums.
Gotcha. And then you talked about there was a potential, but less likely fungal infection. You kind of mentioned maybe even getting a crypto, histo, cocci, blasto.
Absolutely, I would still do those.
Okay.
My general philosophy is that there's a group of diseases that kind of follow the same pattern. And while they have differences in what they do, the Venn diagram includes overlap of all of them, at least at one point. And so my philosophy is if I think of one, I think of all of the other ones. And that's crypto, histo, blasto, cocci, tuberculosis, non-tuberculous mycobacteria, sarcoid, and lymphoma. There's just such a huge overlap between these diseases that I think if one of them enters your mind, all the other ones should. Especially if the one that enters your mind is sarcoid, because sarcoid is a diagnosis of exclusion. And unless you've excluded all the other ones, it's not sarcoid. And one of my favorite patients carried a diagnosis of sarcoid and was managed for sarcoid for 17 years before I cured his sarcoid with amphotericin and itraconazole. Great point. Exactly.
All right. Well, let's see what we can give you, Dr. Spec. So we have the induced sputum that you asked for. We have induced sputum aerobic culture that is showing excessive or pharyngeal contamination, so not particularly helpful. We have induced sputum AFB culture ×3 that are negative, and this is the final culture result, negative. And we have 3 induced sputum mycobacterium tuberculosis PCRs that are negative. We have a T-spot pending, and we have some of this fungal workup that you've requested. The team also got an induced sputum ova and parasite. When would you get a induced sputum OMP versus a stool OMP?
I'm not sure I would do that in a patient who's healthy. And honestly, if I thought that we were dealing with strongyloides hyperinfectivity syndrome, the answer is to just treat. The thing that comes to mind more would be paragonomyosis. So if she had, she actually, she's been in a place that has the classic paragonomyosis, and she's also in Missouri, which has its own endemic paragonomyosis. But the pretty much exclusive way we get our endemic paragonomyosis is with people who have gone down the river and eat a live crawfish. And so that usually means that they're between the ages of 14 and 25, male, and the risk factor was preceded by the words, "hold my beer."
Yes. Fair enough. All right. So let's just briefly touch on the room workup. Just given these imaging findings in her history, is there anything in particular that you would want rheumatologic-wise or immunology-wise?
I think at this point, rheumatology is becoming less likely than it was in my initial present discussion. But I would kind of look at do the thing that rheumatologists hate and kind of cast a little bit of a broader net. So kind of do some of the serologies, but I suspect that they're likely to be negative. And if I was making that decision as a consultant coming in a day 2, let's say, where we have the data we have so far, I would probably not be asking for those initially.
And I think the primary team agreed with you wholeheartedly. They had an ESR that was elevated at 92, and then ANCA that was mildly positive, but myeloperoxidase and proteinase 3 antibodies were undetectable. Do we make anything out of this ESR that's elevated?
Yeah, ESRs are at that level can be elevated for many, many reasons. So I don't worry too much.
Yeah, that's fair. All right. So just to recap, I know that TB is on the differential, but we have 3 negative TB PCRs from induced sputum. We have 3 negative induced sputum AFB cultures. What would you like to do now?
So the one thing that's important about negative TB is that it still can be TB. The tests are far from perfect. Even fully negative cultures can still be tuberculosis. And a big thing to worry about in that situation is, has the patient been treated with antibiotics? So Levaquin is actually a pretty decent tuberculosis drug. And so if she was given Levaquin or some other agents like moxifloxacin, for example, they could sterilize the cultures, but not actually treat her TB even close to well enough. So that would be a thing to look at initially. And plus also, even if they haven't been treated, negative is still possible. And then you go for tissue.
At least in the EMR for the 2 years preceding this hospitalization, there's no records of her getting any antibiotics.
That is remarkable.
All right. So with these negative eval, I mean, when do you consider doing a bronch and just getting bronchoscopic samples?
So pretty early on, I think we need tissue. Plus, also, I think we need an evaluation of her larynx to see why she's hoarse. Presuming that was actually a significant component of her presentation, that it wasn't just really mild hoarseness, I would want ENT to look at that first, because if there is a big nodule there, that's a easier thing to get to than some of the bronchoscopy, I presume, although I'm not a proceduralist.
So she did follow up with ENT outpatient, and they did take a look, and the vocal cords were unremarkable, no nodules that were seen.
Okay, then I definitely would proceed to a bronchoscopy.
Okay, perfect. So they got pulmonology involved, and they did do a bronchoscopy with lavage. On the bronch, they did see these dark hyperpigmented mucosa in the trachea and main carina. Is there anything significant about having these kind of dark spots?
They're not normal. I don't know of a specific thing that it will connect me to dark spots. I think that they're probably, my guess would be that we're looking at necrotizing granulomas, and that's why they're dark, because there's a component of necrosis or some sort of bleed. But I do not know of a specific association with something.
Well, lucky for us, they did get biopsies of those areas, and they also did endobronchial ultrasound with transbronchial needle aspiration of some lymph nodes as well, a paratracheal and a subcarinal lymph node. We do have the BAL cell count from that lavage. What do you make of this BAL cell count?
There's a lot of macrophages. The numbers are not that high, but the high number of macrophages can also, I would think, would push us more towards like a granulomatous disease.
And the pulmonology team in interpretation of the BAL, they thought it was actually largely unremarkable. Just seeing the large number of macrophages can be normal, seeing greater than 80%. So based on this cell count and the BAL, what cultures do you want to be sent on the BAL fluid, and what cultures do you want to be sent on that lymph node aspiration?
For me, the most important ones are going to be fungal and AFB. But honestly, we could, when you're doing that anyway, might as well do bacterial. But those are the ones I'm thinking of more likely.
Gotcha. All right, let's take a look at what they got. So they got a pneumonia PCR, the BAL, that was negative. They got an aerobic culture that showed upper respiratory flora, so super helpful. We got a Mycobacterium tuberculosis PCR that was negative, HSV DNA PCR that was negative, a CMV DNA PCR that was negative, and you know those AFB cultures and mycology cultures take some time to come back. So, so just to recap, we have 3 induced sputum TB PCRs that have been negative, 3 induced sputum AFB cultures that have been negative, and now we have a TB PCR BAL that is negative. Can we say that we've excluded or ruled out tuberculosis at this point?
We cannot. Tuberculosis is sneaky. It's not uncommon. I think I would say about 80% of cases that I've diagnosed here at Barnes, I've kind of looked at it and I'm like, that's probably TB. There's so many things that are pointing away from it. It's not TB. And then it ends up being TB. I'm like, God. And honestly, so with TB, you just really, honestly, very similar to mycology, you have to cast a wide net. And if more than, let's say, 20% of your tests are coming back positive, you're probably not thinking of it enough and you're missing a lot of cases.
Fair enough. Well, our pathologists were hard at work and they were able to get us a speed read on that pathology from the biopsies. We are, graced by Dr. Margaret Axelrod, who's going to discuss pathology. She received her Bachelor's of Science from Georgetown University, subsequently received her MD PhD from Vanderbilt University School of Medicine, and she's now in the Physician Scientist Training Program at WashU Pathology Residency. Thank you so much for coming and joining.
Thank you all for having me. Unlike Dr. Gutierrez, I've only done this conference twice now. And while I do know the diagnosis, I'm not sure how helpful I will be, but happy to share what we have found. So this patient underwent a bronchoscopic biopsy and they had fine needle aspirates and core biopsies. I'm just going to show you the cores because they're fairly similar. So this is what we got for the lymph node level 7. As you see here, this is just blood. This is not a lymph node. This happens sometimes in the procedure. So this particular biopsy is not super revealing. So part B, they biopsied also the level 4R lymph node. And on this one, we got this tiny fragment on the bottom here that looks like some lymph node capsule with some anthracosis, but really not a whole lot of lymph node tissue there, mostly just blood. Nothing, no granulomas, no evidence of malignancy in this biopsy also. And then the last biopsy sample that they took was from the bronchus. I presume they were biopsying one of those dark spots. And this is the whole biopsy. You can see this crushed fragment of bronchus. And when you look a little closer, there's just some intact epithelium up there, and then some more anthracosis and crushed epithelium. But again, we don't see any granulomas. We don't see any evidence of malignancy. And these are our reports for that, as well as the report for the FNAs as well, where we didn't see anything that would be particularly helpful to y'all. On the FNA, we did see some necrosis, but it was still a minimal sample and not enough for us to help you out with what might be causing that necrosis.
All right, Dr. Spec, what are we thinking?
I'm sticking with what I had. And so I think we're going to find some answers on the cultures and the serologies. I wouldn't be surprised if she had a positive T-spot and it turned out to be something completely different. But at the same time, I would also say that if the serologies are negative and we are making the diagnosis finally on culture, which can take weeks to happen, at that point, you don't want to keep the patient in the hospital. Because the people, and you're looking really for tuberculosis here is the issue. She seems to be stable. If she's unstable, you would start TB therapy regardless of the tests and follow up and see what happens. And if she is stable, it's actually better to send her home and just say, don't go out in the community too much because she already exposed her whole entire family. And it's really just more of a risk to the healthcare workers who are in-house if we're going to be keeping her for 2 to 3 weeks at a time without a diagnosis. And we think it's likely to be TB.
Gotcha. So we are thinking likely TB. So just giving you the fungal workup first, we have our serum cryptococcus antigen that was negative. Our induced sputum ova and parasite was negative. Histoplasma antibody urine antigen histoplasma was negative. Blasto antibody negative. Coxi antibody negative. And our BAL mycology culture still cooking, but no growth to date. And the fine needle aspiration of the mycology culture also no growth to date. But we get a T-spot that's positive. We still have some no growth to dates on those BAL, AFB culture and the fine needle aspiration AFB culture, but it seems like at this point, like you said, we're just going to empirically treat this patient. Is that
Yeah,
right?
it seems reasonable to empirically treat, depending on how good at follow-up this patient is. She seems to be pretty stable. She's lost 11 pounds in 11 months. It could be reasonable to send her home without treatment and await for the growth of the cultures. But it would also be reasonable to start her on 4-drug therapy because this looks very much like tuberculosis.
Would you adjust your empiric treatment given the elevated LFTs in this patient?
I think that the LFTs are trending down from the previous episode where she had the eosinophilia and what she did with ivermectin. I would probably be okay with that. They're not terribly high, and having a little bit of an elevation in LFTs at the start of therapy from an unrelated cause doesn't necessarily predict that she's going to have a drug-induced liver injury. There's no association between the two. And so the worry is that she might have less reserve. So if she was cirrhotic, then you might want to worry about it. But really, with mild elevations, I don't worry about it too much.
Gotcha. Well, and weeks later, we finally get the diagnosis. The mycology cultures came back negative, but the AFB cultures from the BAL and from the fine needle aspiration come back as Mycobacterium tuberculosis complex. So, Dr. Spec, what do you think is the diagnosis in this case?
Close your eyes, lean back, think deep for 5 seconds,
Yes.
and then say tuberculosis.
Very good. Thank you so much, Dr. Spec. Yes.
I think fever and granulomatous diseases is hit or miss, and it can be really hard to capture it, especially if you have people who come from cultures where a higher level of discomfort may be acceptable. And it's only on 4th or 5th investigation, sometimes you tell them like, yeah, I just wake up and I'm sweaty at night and I don't, it's because there's less circulation in America. They say things like that. When I'm in Laos, we keep our windows open and here I can't, so it's stuffy, so I get sweaty. You get things like that a lot. There's a lot less testing but also at the same time, tuberculosis can present without a fever in a decent percentage of our patients.
Gotcha. All right, just briefly, I know we're running over time, but given the patient's positive T-spot, previous residence in TB endemic area Laos, and the public health benefit associated with the controlling tuberculosis, the ID consult team, like Dr. Spec was saying, recommended empiric treatment despite the multiple negative TB PCRs and while the AFB cultures were pending. Given the elevated LFTs, they did make an adjustment to her therapy. She was treated with 10 months of rifampin, ethambutol, and moxifloxacin instead of the typical RIPE therapy. We'll talk a little bit more about that in a second, but her respiratory symptoms completely resolved on subsequent PCP visits. And frankly, I didn't see any mention of her hoarse voice after this admission either. 4 months after the hospitalization, patient's LFTs normalized and could be potentially from various things. One being the strongyloides and now being treated, which is kind of what I'm favoring, but they also stopped her atorvastatin in the hospital as well. And then also you always have to kind of wonder with the TB treatment, was there potentially involvement? And now that it's being treated, it resolves. We do have some interval imaging for Dr. Gutierrez, just to briefly walk us through.
All right. I think the follow-up is interesting from an imaging point of view. During the hospitalization, there wasn't any change. Again, there was nothing in the abdomen. Now, if you look several months after treatment, you can see that the nodules are resolving, and now you see that there are areas of traction bronchiectasis. So there's some fibrosis that is developing in those areas, particularly in the right upper lobe. The lymph nodes, how they progress is also interesting. This is when the patient was admitted and the patient had a lot of necrosis in their lymph nodes. And as you can see on the follow-up, 4 months later, not only are they getting smaller, but they are becoming calcified. And the final exam radiograph that I wanted to show you is the presentation, again, the cluster of nodules, right upper lobe. But as you can see, they're starting to dissipate and developing these lines. Does anybody see anything else? Now, if you look at the trachea, you can see that it was straight when the infection was going on, and now it's starting to deviate to the right. So there's volume loss in the right upper lobe. We don't have any more recent exam, but I bet you that by now there's probably more retraction, more fibrosis, and maybe more calcification. So
Right. Thank you so much, Dr. Gutierrez. So just some brief teaching points about TB. Mycobacterium tuberculosis complex refers to infection by any member of the genetically related mycobacteria, including Mycobacterium tuberculosis, bovis, africanum, and others. Diagnosis and treatment of the Mycobacterium tuberculosis complex species is generally similar, but there are certain species that can have resistance to certain medications. For instance, Mycobacterium bovis has been found to be resistant to pyrazinamide. Diagnosis of pulmonary tuberculosis, that's kind of been the crux of this CPC, but for suspected pulmonary TB, the American Thoracic Society, Infectious Disease Society of America, and CDC recommend interferon gamma release assay test in those who are likely to be infected. They recommend AFB smear microscopy to be performed. Testing 3 specimens is considered the normative practice in the US. And again, the biggest learning point from this case is that a negative smear does not exclude pulmonary TB. They also suggest nucleic acid amplification tests. As you guys remember, we had multiple negative TB PCRs. And then they suggest sputum induction rather than bronchoscopic sampling as the initial respiratory sampling method, and then bronchoscopic sampling in those who are unable to get an induced sputum. And then briefly about treatment, as you guys remember from medical school, we were taught the RIPE therapy, 2 months of 4 medications followed by 4 months of 2 medications. So the 2 months of rifampin, isoniazid, pyrazinamide, and ethambutol followed by 4 months of isoniazid and rifampin. That is actually changing, and the societies actually came out with updated clinical practice guidelines for drug-susceptible pulmonary TB in January 2025. And they conditionally recommend a 4-month regimen, so 2 months of isoniazid, rifampicin, moxifloxacin, and pyrazinamide, followed by 2 months of isoniazid, rifampicin, and moxifloxacin. Guidelines are relatively unclear regarding treatment of TB and acute liver injury and severe liver disease, but when patients have a baseline ALT greater than 3 times upper limit of normal and it's not attributable to TB, regimens with fewer hepatotoxic agents are preferred, and it seems like pyrazinamide is often omitted due to higher risk of drug-induced liver injury. All right. Thank you, thank you everybody for coming to our CPC. And thank you so much, Dr. Spec, Dr. Gutierrez, Dr. Axelrod.
Like, what are PCRs are not terribly, they're not terribly sensitive to genetic cases. So they're very helpful in the positive cases to confirm the diagnosis. They're actually also even more helpful in smear positive cases if the PCR is negative, because that's actually pretty highly predictive. It's not. It's not a so whenever you have a low organ in the world, it's you're gonna have a negative PCR. Same with not Steve.
But even like, I was surprised that you went into the AL one, like, if not, it would be more sensitive. Like, is it not testing like for my, I don't know, like,
I mean, that's really what it boils down to. Not to be perfect, it's just that if you want to do now, there's a reason why a lot of people become master questions. So it's a difficult piece to diagnose, but it's extremely difficult. Because we see so little worldwide, many breakdowns are so good. We are not.
and the other question, why do you think, like, was the transfer is not about active like age and like
Age is worldwide oversight.
Thank you.
Thank you.
Thank you so much.